First of all, as far as the management of the umbilical cord is concerned, it is recommended to delay clamping by at least 60 seconds, and ideally after aeration of lungs. The new element is also the recommendation of cord milking, which can be used instead of delayed cord clamping when delayed cord clamping is not possible. And this can be considered in infants over 28 weeks of gestation. It should not be used in the most premature babies. Another change is the approach to the management of infants born through meconium-stained liquor. And currently in the non-vigorous infants, the immediate laryngoscopy should not be performed with or without suctioning just after the delivery, as this may delay aeration and ventilation of the lungs. So currently it is only advised when we fail to aerate. And then another element is the use of laryngeal masks. So if the face mask ventilation is not successful, or if tracheal intubation is not possible or was unsuccessful, the laryngeal mask airway can be considered as an alternative method to establish an airway in infants over 34 weeks of gestation. Another element which is included is the inflation pressure. So if there is no response to initial inflations despite an open airway, then in the recommendations you can read that it's advised to gradually increase the inflation pressure. The initial starting pressure for premature infants is currently 25 centimeters of water, and then we titrate the pressure depending on the response. And in terms of the approach to oxygen supplementation for the preterm infants, this has also changed. It is currently advised for full-term infants and preterm infants at 32 weeks of gestation and above to start with air. But between 28 and 31 weeks of gestation, we should use the concentration between 21 and 30%. And for the most extremely premature infants below 28 weeks of gestation, we should start with 30% of oxygen. And then based on the pulse oximetry readings, we should titrate the concentration of oxygen, aiming to achieve saturations of 80% or above at 5 minutes of age, as this correlates with the outcome in these infants. And finally, when chest compressions are needed, the inspired oxygen concentration should be increased to 100%, and we should consider securing the airways with tracheal tube or other means. The reason why we recommend delayed cord clamping is that it allows the transfer of blood from placenta to the circulation of the infant after birth. So these benefits include improvements in terms of hematological indices over the first months of life. And especially this is important in the preterm infants, and we know that if this procedure is used then in the preterm infants, this may reduce the need for transfusion. We also know that in the preterm infants, delayed cord clamping has a beneficial effect on survival. These patients are more stable in terms of their blood pressure, and they require less hemodynamic support. With the delayed cord clamping, this may not always be possible, So there are some situations in which this is contraindication. So first of all, if the patient requires resuscitation, then in order to be able to support the patient according to the current guideline, we may have to cut and clamp the cord early. There are some situations in which the placental blood flow is compromised. It may be associated with placental abruption, cord prolapse, or maternal hemorrhage, and in these situations, we also cannot use delayed cord clamping. Cord milking may be an alternative in situations, and as I said before, it is also included now in the guidelines. But I would say that most infants will benefit from the delayed cord clamping. I would say maybe few percent of those babies that require more advanced resuscitation with ventilation and perhaps more advanced measures such as chest compressions and drug administrations. In these cases, you won't be able to use it, but I would say no more than few percent of the population of the patients that we are looking after. Well, it's important to remember that it's not instead of auscultation or pulse oximetry. It's an additional element. So by default, we would start with auscultation just after birth, but we have to remember that in some situations it may not be very accurate, and it will not be as accurate as ECG. And the other problem is that it is intermittent. So we would either have to stop our interventions, or one person would continue and the other one would perform the assessment. So the use of ECG allows for continuous assessment, and the assessment of heart rate will be more accurate as compared to auscultation. And it may also be more accurate than the assessment using pulse oximetry, especially in situations in which the patient has got low perfusion. In such situations, it may be more difficult for the pulse oximeter to detect the signal. It may take longer, and B, it may be less accurate. And we also know that the time from the placement of the electrodes to the moment until we get the reading on the monitor is shorter as compared to pulse oximetry. So before the sensor placement and again presentation of the values of saturation on the screen of the pulse oximeter. So as you can see, there are several benefits. However, I would like to stress the fact that it's not instead of pulse oximetry; it's an additional tool. So we need to assess our patients clinically using standard stethoscope. But then, especially in those babies that will require resuscitation, we should use both pulse oximeter and ECG monitor, as this may help to optimize our interventions. It is extremely important. Neonates, after they are born, they can get cold very easily, especially if they were born preterm. We know that hypothermia may be associated with increased risk of mortality and morbidity, as it may result in lower oxygenation and the increased risk of metabolic acidosis. So it is really important to remember about it from the start. So even if we have to focus on, for example, ventilatory support, other interventions, we should not allow our patient to get cold. And we also know that the temperature on admission to the neonatal unit is a strong predictor of mortality and morbidity, as I said before, both in term and preterm infants. And in preterm infants, it may be difficult to achieve this, to keep these babies at a normal temperature. And in those infants, we should first of all remember about appropriate temperature in the delivery room. So the smaller the baby, the higher the temperature. With the most premature infants, we should keep the temperature as high as 25 degrees Celsius and above. For these very premature babies, we may have to use several methods. So not only the standard means that we use, which is for a full-term baby, this would be drying and covering the baby with a towel, for example. In the preterm infants, we would use a plastic bag to cover them to prevent from the temperature loss, but we may also have to use other methods. And of course, we keep these babies under radiant heater if they require additional support. But in the preterm infants, we should also consider additional methods such as the use of warmed and humidified gases, as it has been shown to increase the chances of these babies to be admitted into the neonatal intensive care unit with a normal temperature. So we've known it for many years, but it continues to be extremely important to keep our newborn patients warm. And in the most premature babies, it may still be a challenge. No bigger challenges than previously. We just need to remember about these slight changes, and we need to remember about implementing them in practice. So it's good to have some additional tools that are now currently recommended. So, for example, the laryngeal masks, to keep them with you, as they may be helpful in situations in which face mask ventilation is not sufficient for the patient. At the same time, when we talk about the airway patency, one of the changes is that we now no longer recommend oropharyngeal airways, especially for the preterm infants. And in just special situations, in special scenarios, they may be helpful for full-term babies. So those of us that were using the oropharyngeal airways, we now should limit this to special situations, because we know that in the preterm infants, oropharyngeal airway may not be the ideal tool to keep the airways open. And apart from that, we should try to optimize what we do. And I'm also aware that not all the tools that are currently recommended may be available in all the centers. Like it was a process with the ECG monitors. They were introduced in 2015. And I believe that currently most of the centers would have such ECG monitors available in the delivery room. However, especially in those countries in which the budgets are lower, it may take a while to have all the resuscitation rooms equipped with all the equipment. I also understand that for example, laryngeal masks may not be easily available everywhere. So it always takes some time to introduce those elements in our everyday clinical practice. The standardized approach to resuscitation among other elements of care help to increase the let's say level of care throughout Europe. So it's strongly encouraged by the European societies such as ESPR to keep these keep this standardized approach. So guidelines are one part. The other part is the training, which is based on these guidelines. We know that the people, the personnel are most important to increase our standards of care.